So, I'm going to talk basically of 3 new technologies in the treatment of hemorrhoidal disease. The first one is the procedure called PPH. It's a procedure for prolapsed hemorrhoids, basically grade 3 and grade 4. The other procedure is the ligature, when you use an energy device with this forceps. And the third one is the THD. We call the transanal desarterialization hemorrhoidectomy. Why new technologies? In the last years, the main concern in the treatment of hemorrhoidal disease, basically by surgery, is the postoperative recovery, mainly the pain, because it's terrible with the traditional surgery. The recovery sometimes is very long, like 3 weeks or 4 weeks, with impact in the time to return to work. So the new data show the results of new technologies. I'm going to show some papers by this author, the Popo, that show the advantage of transanal desarterialization hemorrhoidectomy comparative with the traditional surgery. And this paper show that THD is a new surgical technique used for the treatment of hemorrhoidal disease, and now we know that it's easy performance and low periosteal risk. This paper includes 44 patients operated with the THD technique for a period of 22 months, and then they realized an analysis of the comparative results, basically versus Milligan and Morgan and Whitehead hemorrhoidectomy. And the conclusion of this paper is the THD, comparative with other methods, it's a very excellent method with aesthetic effect, with shorter hospital stay and less use of analgesic and less discomfort in the postoperative period. This is another paper with 666 patients, comparative ligature, this is the other new technique, versus traditional surgery for prolapsed hemorrhoid with a follow-up of 2 years. And they found very similar characteristics in the group of the patients. And the results shows hospital stays 1.5 days, no complications like bleeding or another complication related with the procedure. And after 1 day, majority of the patient was discharged of the hospital. Most of the patients resolved the symptoms after the surgery. And in the follow-up, most of the patients were satisfied with the surgery. After 1 year, 2 patients had additional excision of residual skin tags. 1 patient developed stricture, 1 patient with fistula, and 3 were treated by anal fissures. The minor incontinence like flatus, 1.7%, and 2% mid bleeding after the surgery. So they conclude that the long-term recurrence after this type of surgery, that means ligature, is very low and is comparable with conventional hemorrhoidectomy. The other technique, the mucosectomy, the rectal mucosectomy for prolapsed hemorrhoids, initially described by Antonio Longo from Italy. This technique basically coat a circle of rectal mucosa, and the hemorrhoid package are repositioned, like show this picture. So this is the preoperative fashion of the surgery. You can see prolapsed hemorrhoids. Then we use this device with a special transparent anoscope, the introducer in the anus. We fix the device with silk, 3 or 4 points, and then we localize the dental line, and 4 centimeters above the dental line we start the suture, and then we introduce the device to coat a circle of mucosa, And then we pull the suture, and finally we coat the mucosa, and then this is the final result. And you can see how introduce again the hemorrhoid prolapse before the surgery. But this type of technique is associated with short-term complications like bleeding of the staple line, anal pain when we collocate the staple line very low, close to the anal margin. The anal pain is a very frequent complaint of the patients, and the urinary retention also is a very frequent complication after the surgery. And long-term complications include chronic anal pain, dehiscence of the staple line, anal fissure, external hemorrhoid thrombosis, and sometimes fecal incontinence when we include fibers of the sphincter in the mucosectomy. This is the results of the Cochrane database in 2006, and this paper show recurrence with PPH procedure 5.7% versus traditional 1% in 1 year of follow-up. After long-term follow-up, the PPH procedure show 8.5% of recurrence versus 1.4% in the traditional surgery. So the conclusion of this paper, of this review, show that PPH is associated with higher recurrence rates and persistence of symptoms in long-term follow-up. So this is the reason of our paper, because in recent years, the major concern of the management of hemorrhoidal disease is the postoperative pain. So new technologies has been developed like ligature, THD, and PPH. I'm going to focus in THD and ligature because we have more experience in both methods. We also done, I have done some PPH procedure, but I don't like this technique because the complaint after the surgery is major comparative with the other techniques. So basically, we had made 2 studies. The first one between June 2012 to August 2014. We compared first 50 patients divided in 2 groups, the group A for ligature and group B for THD hemorrhoidectomy. In both groups, the majority of the patients had a grade 3 hemorrhoidectomy. So I'm going to briefly remember the classification of hemorrhoids. Basically, it's for internal hemorrhoids. The external doesn't have any grade, any classification, independent of the size. But the internal, we can classify in 4 groups. The grade 1 is a little bit bigger comparative with normal hemorrhoids. The grade 3 is prolapsed, but they reduce spontaneously, and grade 4 is prolapsed permanent. So in this group, we include grade 3, 80% of the patient, and grade 4, 15%, and grade 2, 5%. And we analyze the surgical time, the hospital stay, postoperative pain, complication, and time to return to work, and recurrence and development of skin flaps. In this table, I'm going to show the demographic data. The average of age for group A, 39 years. For group B, 40 years. The distribution by sex, 80% male in group A and 55% in group B. The majority of the patient had a grade 3 and grade 4 internal hemorrhoids. Most of the patients complained about bleeding, itching, and burning. And the results in the group A, the surgical time, 10 minutes versus 11 minutes in group B. The average of bleeding, of surgical bleeding, was 5 cc's in both groups, and the hospital stays in the majority of the patient 1 day. Some patients were discharged in short hospital stay, less of 1 day, but we put the majority of the patient in 1 day. So any patient had postoperative bleeding, and any patient develop urinary rotation after the surgery. The pain was evaluated with the visual analog scale, and very similar results in both groups, and the time to recovery in average was 8 days for group A and 7 days for group B. So just 1 day of difference with no statistical significance. And the time to return to work, 11 days in the group A versus 10 days in group B, with no significant difference. So this is a very short video that shows the technique with ligature with a special energy device. So we take the hemorrhoid with a forceps, we lift the internal hemorrhoid, and then we use this device. It's very easy, fast seal and cut of the internal hemorrhoid, so you can see almost nothing of bleeding. And on the final of the procedure, you can see the perfect seal over the internal hemorrhoid, so you can see the seal. We don't use any suture, and almost no bleeding after the resection of the internal hemorrhoid. So now we are very careful with the management of the skin, because this device produces high temperature, so we can inflammate a lot the skin, and after the surgery the patient complain more pain, or sometimes the sensation of foreign body in the skin. So initially we cut the skin, and then over the mucosa we use this device in order to decrease the pain in the postoperative time. So in this study, the follow-up was 24 months without any evidence of recurrence of disease, and 3 patients developed skin flaps, but none patient required surgical treatment. So the other experience is with a sample of 180 patients during May 2011 to June 2015. So we include hemorrhoids grade 3, 11%, grade 4, 7%, and mixed hemorrhoids, that means component internal and external, in almost 80% of the patient. With a predominance of male sex, 63%, we analyze the surgical time, the bleeding, postoperative pain, complication, recurrence, time to recovery, and time to return to work. So this table shows the age, 42 years in average, with a predominance of male sex, the majority with a diagnosis of mixed hemorrhoids, then grade 2 and grade 3. Most of the patients had bleeding, itching, and sensation of foreign body before the surgery. The surgical time was 15 minutes in average, with very low bleeding, just 5 cc's. Hospital stays 1 day, urinary rotation 3%, and the recurrence only 2.3%. That means 4 patients during the follow-up. That is very low compared with other techniques. And the average of recovery, 10 days, and the time to return to work, 14 days. With the traditional surgery, sometimes it's very long, the time to recovery, sometimes 2 months, and the time to return is almost the same time. So both studies, we control the postoperative pain with acetaminophen, 1 tablet 3 times a day. Sometimes we combine with ketorolac 10 milligrams 3 times per day. In 5 patients, we need the combination of acetaminophen, but with tramadol. All the patients, we administer prophylactic antibiotics with metronidazole, 400 milligrams, 3 doses, and then 5 days by oral via. In all the patients, we did the laxative, like polyethylene glycol, and a topic cream with ketanserin and benzocaine in order to control the pain in the postoperative fashion. So in conclusions, the recent advances in minimal invasive treatment have provided adequate, rapid recovery. The time of recovery and time to return to work is also decreased with both techniques, ligature and THD. So both techniques demonstrate appropriate management of the disease with very low recurrence rates, and the postoperative pain is very minimal, and the complication rates is very low. Thank you very much. You have any question?
Thank you, Dr. González. I want to ask you two questions. Did you expect the complication of your procedure is smaller or bigger than the other procedure? This is the first question. The second question, did you search for hemorrhoids? Sometimes it is a secondary note, right? After portal hypertension, something like that. Did you search for the cause, or you treat hemorrhoids itself?
Well, the main complication for these procedures is basically the postoperative bleeding, and the main concern is the management of the pain.
Did you expect the bleeding more as a method or less?
Less. We expect less, almost nothing, almost zero bleeding with these techniques. The rate of bleeding with the traditional surgery maybe is less of 1%, but sometimes imply a new surgery to the control of the bleeding. But the main concern, the focus of both or three techniques, I don't use the PPH, I don't like, but I use ligature and THD, is decrease the pain and the time to recovery. Because with the traditional surgery, with the resection with cautery or scissors or scalpel, is high the incidence of pain, and the time to recovery is very long, sometimes 2 or 3 months. So these techniques decrease significantly the time to recovery and time to return to work. The other frequent complication is the urinary retention. Sometimes it's associated to the procedure, and sometimes it's secondary to the anesthesia. The majority of the patients, we made the surgery with regional anesthesia. That means spinal blockage, and that procedure is associated with urinary retention, maybe 5 until 10%. We have very low rate of urinary retention, but it's one complication described by this technique. When we have a patient with other morbidity like portal hypertension, it's not convenient to use this technique. This patient has a very special bleeding secondary to the portal hypertension, so sometimes it's no good candidate to surgery. We prefer decrease the portal hypertension with a tips or with a medical management, or sometimes use just ligation of the hemorrhoids, but not a invasive surgical technique, because sometimes the bleeding is under or difficult to the control.
I asked you, do you search for primary cause for this hemorrhoids or no? All your cases?
Well, the cost is very similar because sometimes the
cause, not the cost. If there is a primary cause for hemorrhoids, or it is secondary hemorrhoids?
It's for the primary.
Right. Thank you.
Thank you. Is there any other question from the audience?
Do you use local anesthetic after the operation for your THD?
Well, the results is very good. We don't analyze the aesthetic results, but also when after the surgery, you can see if the skin flaps of the external component is completely reduced, or sometimes we need to resect one or more skin flap in order to give more aesthetic results.
Do you use local anesthesia?
Regional.
Post-op?
Yes.
Yes. One more question is, I found in my doing THD, 1 out of 15 or maybe closer to 1 out of 20 patients have quite extreme pain, which lasts for a few days. Have you found that as well?
Just in 3 or 4 patients. I don't know exactly the reasons, because we made the procedure with the same technique, but maybe sometimes have a very low threshold to the pain. I don't have any other reason.
And what do you do for those patients? Because I found them very difficult to treat because they're pain up to 6 weeks after the operation.
Sometimes we use a combination of acetaminophen with tramadol, and very few patients, maybe 1 or 2, I remember, we use intramuscular analgesic like Voltaren, for example, one or 2 doses. And sometimes we use a very low dose of steroid in order to decrease the inflammation after the surgery. But it's very rare, just 3 or 4, or almost 200 patients.
And you couldn't find a reason for those as well?
Not really.
I also have a question. So I'm not an expert in the field, so excuse me if it's a naive question, but I was wondering, the recurrence of these hemorrhoids, are they a consequence of the surgical intervention, or would they have come back by themselves?
No, it's not the technique exactly associated with recurrence. However, the PPH, how I show in the Cochrane study, is associated with higher rate of recurrence. However, there are many factors to development of hemorrhoids, like obesity, low fiber in the diet, sedentarism, overweight, pregnancy. So after the surgery, the patient needs to modify the habits, decrease the weight, increase the fiber intake in order to decrease the possibility of recurrence.
And do you sometimes see fibrosis occurring after surgery?
The what?
Fibrosis.
No.
So tissue destruction. No. Is there any other questions? I think we still have time for some questions. Otherwise, we already have coffee. Let's have some coffee then. Thank you very much.
Thank you.